really informal. So if you have a question, stop, interrupt. I'm going to ask questions. There's HIPAA, so if you don't want to share with the group, that's fine. But if you want to raise your hand and answer, that's fine too. I put some notes because I thought we were doing a PowerPoint presentation. So just remind me what's going on. But the most important thing about you guys being here today is to get some knowledge, to empower yourselves, to understand. I think as a medical community in the past, we've done a really poor job of helping educate people, particularly women, and we'll talk a little bit about that now. So these grassroots things are great for you guys to take this back to your friends and family and hopefully have an impact and help each other out, all right? So one of the first things we're going to talk about are hereditary syndromes, right? So that's a syndrome that runs in a family. That's one that gets passed down from your grandparents and you pass down to your children, okay? And the most common ones that affect breast and ovarian cancer are obviously the hereditary breast and ovarian cancer syndrome, which is most commonly associated with BRCA1 and BRCA2 mutations, okay? The other one is Lynch syndrome. Lynch syndrome used to have another name. It used to be called non-polyposis colorectal cancer syndrome. And it was actually discovered by Dr. Lynch, who looked at these families that had colon cancer. And what he found was all the men in this family, when you looked at the generations, developed colon cancer. And they called it Lynch syndrome, but he was kind of a modest guy. He said, no, let's call this non-polyposis colorectal cancer. Then they eventually got around to looking at women in the family, because right, women always come second in medicine. And when they did, they saw, in this family, not only do women get colon cancer, but they get endometrial cancer. And in fact, they get it just as frequently and maybe even more so. And so they discovered this family of Lynch syndrome, women get colon cancer, but they get also uterine cancer and also can get ovarian cancer. So from calling it non-polyposis colon cancer syndrome, it's back now called the Lynch syndrome. So those two syndromes are the ones most commonly associated with hereditary breast and ovarian cancer syndrome, all right? The hereditary breast and ovarian cancer syndrome is most associated with BRCA1 and BRCA2, as we've talked about, right? BRCA1 increases your risk of developing breast cancer as high as 80% a lifetime risk, okay? BRCA2 also increases your risk of breast cancer up to about 60%. When you look at BRCA1 positive women, they have a lifetime risk of developing ovarian cancer as high as 50%. And when you look at BRCA2 patients, they have a risk of developing ovarian cancer as high as about 40%. And we thought the story kind of ended there. But what we found over the last couple of years is we have more mutations that now come up. So there's a new mutation called PALB2. Has anybody heard about PALB2? Yeah, so PALB2 is a new mutation that we don't really know a lot about. But women who carry this new mutation, PALB2, have a lifetime risk of almost 63% of developing breast cancer. And we know they have an increased risk of developing ovarian cancer. We haven't figured out what that risk is yet. And there's another mutation called RAD51. Have you guys heard about that? So RAD51 also increases your risk of breast cancer and it increases the risk of ovarian cancer. Again, we just don't know how much. So right now, ASCO, the NCCN, they recommend that women who have these PALB2 mutations and these new RAD51 mutations, come talk to someone and see, should you have a risk-reducing operation? We know you're at increased risk, we just don't know how and we're not sure when. And the reason this is important is because, again, we haven't done a good job as doctors testing women. My wife's an internal medicine doctor, and the testing reps tell me all the time that she has one of the highest testing rates of any internal medicine doctor, but more than most OBGYNs. I like to think it's because of me, but no, she's a smart woman and she does it on her own. But it's great. And family history is so important. You're gonna have 15 minutes when you go see your doctor. They probably don't even ask you about your family history. And family history changes from year to year. You find out that someone else was diagnosed with something. So if your doctor's not asking you this, you need to be proactive. And if you have significant family history, you need to get tested. And some people say, well, I'll do 23andMe. They test, right? So yes and no. The problem with 23andMe is they look at only founder mutations. And that's only a small amount of those genetic mutations. So you can get a false negative. So you can go to Walgreens, you get your 23andMe, send it, comes back and says, oh, I don't have BRCA. Good, I'm in the clear. Well, that's not necessarily the case. You don't have the founder mutations, but you may have another BRCA mutation. You may have PALB2, you may have RAD51, and we don't know. So you want to do 23andMe, that's great, but it's not a substitute for genetic testing. You really should see a genetic counselor. Go ahead.
So with the new mutations, are those new mutations now added to the genetic testing profile? And if they are, then what does the counselor relate to the patient if we don't know the risk the increased risk of developing certain cancers if they come back positive? Do you know what the general recommendation
Yeah.
is?
So the recommendation is to go see someone like me, which puts
Oh,
me in a
okay,
test spot.
okay.
Yeah.
I was helping you out.
But the
Okay.
other good thing about those testing is, for example, we didn't know what these genes meant, right?
Okay.
And so 5-7 years ago, we'd get the test result back and says, you know, you have PALB2 mutation. I don't even know what that means. But as we find out now, and I don't speak for any of these companies, but you know, Myriad, I like them. I have some problems with them because they don't share their data. But in any event, Myriad keeps your data. And if you had a PALB mutation 7 years ago, we didn't know what it meant. And now we know PALB mutations increase risk of breast cancer. Myriad will notify you and will notify your doctor, hey, your patient, Miss So-and-so, has a PALB mutation. This puts her at increased risk of breast cancer. 23andMe and those companies yet don't do that. So going back to your other question, what does it do? So you have a counseling session, and then they'll say, you know, go talk to John, see what a potential surgery would entail. The other thing that's important is family history. So again, you don't get that from a test. So if you come to me and you say, listen, I have a PALB2 mutation, and yeah, my mom had ovarian cancer, and so did her sister, it's a no-brainer. You're at increased risk of ovarian cancer. If you have PALB2 mutation, no one in your family has ovarian cancer, a lot of breast cancer, you know, the plus minus, do we remove your ovaries or not? All right.
Okay.
So it's very important to speak with a counselor. And so I wrote a paper 3 years ago looking at, we call it the white paper for genetic counseling. At the time we wrote that paper, we had one genetic counselor in the entire state of Florida, which is obviously unacceptable, right? So now we have 3 just at the Miami Cancer Institute. So that's where I work, down in South Florida. So that's a huge impact on our community, right? So now we have access to these. But even if you can't make it all the way down to Miami, if you have Myriad testing, they do have counselors that you can Skype with and whatnot. But obviously, a personal counselor I think is a little bit better. So we have a better understanding of genetic counseling and what it means, right? So really important. So sensitivity we talked about with BRCA1, BRCA2, PALB2 now, right? RAD51. So these are things that are important. So what happens if you are screened for this, right? Or who should get screened for this? So who should get screened for genetic susceptibility to breast and ovarian cancer? Do you guys know? Everybody sounds like a good idea. So any woman who has ovarian cancer should be offered genetic counseling and testing. And it used to be kind of an altruistic thing. Well, you should get it done because maybe we'll find it in your family members. Now we have treatment that's based on your genetic results. So now you don't have to be altruistic, you can be a little selfish to get your counseling. But every woman with ovarian cancer should be offered and should undergo genetic testing. Now we've known this for years. And even in the best centers in the country, Sloan Kettering, MD Anderson, WashU, our rate of genetic testing in women with ovarian cancer is dismal. Now we can't make you get tested, but even with that, it's really, really poor, right? So how about women with breast cancer? Should they undergo genetic testing?
Yes.
Everyone?
Yes.
Yes, absolutely, right? So the American College of Surgeons last year said every woman with a breast cancer diagnosis should undergo genetic testing, okay? That wasn't the case in the past, right? But everyone with a breast cancer diagnosis should undergo genetic testing nowadays. Again, not just to look for BRCA, but these other mutations, okay? And it's important. I'll give you a quick story. So I was covering my partner a few years ago. He was on vacation, a patient of his came in, she had ovarian cancer, and I was just going through her chart. I said, you know, you've never been tested to see if you carry a mutation. And he said, well, I only have boys, and I already have ovarian cancer, why should I get tested? I said, well, actually, you know, if you carry a BRCA mutation, if you have a BRCA2 mutation, men are at increased risk, right? So men with a BRCA mutation are at increased risk of breast cancer. We certainly do breast exams, and we're certainly not getting screened, and at increased risk of prostate cancer and pancreatic. I didn't think anything about it, but like I said, she came in. A few months later, she sees me in the office and says, hey, Dr. Diaz, you know what? I did get testing, and I'm BRCA2 positive, and my 2 sons are getting tested now. So thanks. So every person should get tested, and this is no longer a disease of just women, right? Men with BRCA2 mutations are at increased risk, and we'll see what PALB2 and RAD51. So it's really important that everyone gets tested. So all women with breast, yeah.
So if you're tested and you have a mutation, but you don't have the BRCA, then when do you get your children tested? If it's a mutation, and at what age would your children be tested ideally?
Yeah, so if you have a mutation that puts you at risk for a cancer, it depends what it is. So let's say they have a BRCA1 mutation, right? So BRCA1, breast cancer and BRCA1 and ovarian cancer occur much earlier than BRCA2. So if you have a BRCA1 family history or positive test, then your children, your women, should probably be tested at least by 30, okay? Because that's the point where you could start some screening. We'll talk about that in a moment. If it's BRCA2, you could hold off a little bit later, but again, you want to screen, and definitely 10 years before the youngest person in that family that had that disease. So if you were diagnosed with breast cancer at 43 and are BRCA positive, but your mom was diagnosed with breast cancer at 38, we go with the youngest person there, okay? Now, do you want to test your 14-year-old? No, because we're not going to do anything with it, and there's no point in putting that kind of stress on a 14-year-old. But a woman who is already in her mid to late 20s, we should have the opportunity to test, because then we can start some screening. We'll talk about in a minute, okay? So, screening for breast cancer. I know Trace told me 15 minutes. I'm gonna run long, so I'm sorry. You guys can cut me off whenever you want. So screening for breast cancer, right? So the guidelines are kind of mixed, and the U.S. Preventive Task Force, ASCO, ACOG, they're all kind of fighting. But you should start screening by 45, okay? Some recommend starting at 40, okay? And that should be an annual mammogram, okay? At 55, you have the option of getting it done every year or every other year. I would opt for every year. Now, if you test positive for BRCA1, BRCA2, PALB2, something like that, and you're not ready to do something risk-reducing surgically, then your screening should be every 6 months. And that screening should be probably a mammogram once a year and an MRI 6 months later. Depending on your breast density, young women have more denser breasts, they may throw an ultrasound in there as well. Yeah, go ahead.
I'm BRCA1 positive, and I am a problem solver, so I went ahead and had my ovaries removed by you. And that was in 2015. And I ended up with ovarian cancer last year. Now my question is, once you're identified as BRCA1, do you think that women should be checked every 6 months, as you said, or every 3 months? Because once those surgeries were completed, nothing was done.
So here's the crust of that. So breast cancer screening works, right? And so again, if you carry a BRCA mutation, you should have screening done every 6 months, okay? Ultrasound, mammogram, ultrasound with MRI in younger patients, okay? What to do with ovarian cancer? So if you're a young patient and you're not ready to do something surgically about your ovaries, we do screening for ovarian cancer. And what we do is every 6 months we get the famous blood test, which is the CA-125, okay? Which is a marker that really is only approved in women who have ovarian cancer. If it's elevated, we can see how it titrates down while they receive the chemotherapy, okay? It really doesn't do much else. In women who are postmenopausal, if it's elevated, that can be an indication something's going on, but it's not a yes or no test. In women who are premenopausal, it can be as high as 200 before we actually have to worry about it. But we get it. And we get ultrasounds to look at your ovaries. And we do that every 6 months. And it doesn't work. So there's no effective screening for ovarian cancer.
With an elevation of 632 CA-125, that's pretty high.
That should cause some pause. Correct.
Right?
Yep. Okay. The problem becomes, though, the normal CA-125 is 35 or 25, depending on the lab, for a postmenopausal patient. So a CA-125 of 37, it's abnormal. Most likely it's not ovarian cancer, right? Because although we're in a group here was a big awareness, thankfully ovarian cancer is not very common. There are only 22,000 cases a year. If you do not carry BRCA mutation and you don't have a family history, your risk of developing ovarian cancer is 1.4%. So it's very low. If you carry those mutations, it's much higher. And that's why screening doesn't work. We're looking for a needle in a haystack. But even in BRCA positive patients, we've done these studies where we do serial ultrasounds and serial 125s, it still doesn't do what we want it to do, which is to catch ovarian cancer at an early stage where it's treatable and curable. So we do it in our 27-year-old and our 30-year-old BRCA1 positive, knowing that it really doesn't work, and we just kind of get to a point where they're ready to do something more definitive. So more definitive, go ahead.
Does the BRCA, you know, you're talking about like removing the ovaries and that type of thing, but does it impact your fertility? The gene, does it impact your fertility before you have all the surgeries?
Not that we're aware of, but, okay.
Question.
Now, yep, go ahead.
This woman said she had ovarian cancer, and she had her ovaries removed.
Yeah.
How then did she get ovarian cancer
So we're
if
gonna
they
get to
weren't
that.
there?
Yeah.
I don't understand,
Yeah.
so.
So, one of the things to do if you carry a BRCA mutation is to do risk-reducing surgery, right? So Tracy talked about her experience about removal of the breast tissue. When you do that though, there's about a 2.7% chance of you finding a breast cancer at that time, okay? When you do a risk-reducing surgery of removing your ovaries and fallopian tubes, there's about a 2 to 3% chance we're gonna find a cancer hidden there. So if you're gonna have this done, it should be done by someone like myself, a GYN oncologist, and it should be done in a place where the pathologist is gonna cut the specimens, do what's called serial sectioning to look for it. And in fact, a lot of what we think is ovarian cancer, we've now learned is probably fallopian tube cancer. So when you look at women who had a risk-reducing procedure and they removed their tubes and their ovaries and they cut them serially, less than 1% of the time when they found a cancer was gonna be an ovarian cancer. Most of the time they found it in the fallopian tubes. And so there was a pathologist at Hopkins who's been talking about this for a little while. And so we think that ovarian cancer really most of the time is fallopian tube cancer. And so one other strategy is, let's say you've had your 2 kids, you're 29, you and your husband know you're not gonna have more kids, but you're only 29, we don't wanna remove your ovaries just yet. One thing you could do is remove the fallopian tubes, and that will decrease your risk. You can still keep your ovaries, still keep your benefit of estrogen until the time that you're ready. And in fact, in women now who are gonna have a hysterectomy for fibroids, we say keep your ovaries, because unless you have family history, your risk of developing ovarian cancer is very low, but we're gonna take your fallopian tubes. And there's even a push that if you go get your gallbladder removed and you're a woman, hey, if you're there, take the fallopian tubes. So if you're gonna have an appendectomy, hey, if you're there, take your fallopian tubes, okay? Because we're starting to think that's where the cancer starts, okay? Now, if you remove your ovaries and your fallopian tube, that decreases your risk of getting ovarian cancer by over 98%. It's not 100%. And the reason being is there's an entity that's called peritoneal cancer. So does everybody know what your peritoneum is? So I use an analogy in the office. So think of your body as a garbage can. Think of your body as a garbage can. Think of your insides as the garbage. And think of the peritoneum as a garbage bag. So the peritoneum is the lining that we all have inside our abdomen, okay? And peritoneal cancer presents like, behaves like, and we treat it like ovarian cancer. So if you have a risk-reducing surgery where you remove your tubes and your ovaries, that decreases risk by 98%, but it's not 0. And when it comes back, it's likely not ovarian cancer, it's likely primary peritoneal cancer that we call ovarian cancer, because that's how it presents. It presents the same way, we treat it the same way, and we include ovarian, fallopian tube, and peritoneal cancers in our clinical trials, because they all present, get treated, and have the same risk factors. So yes, you can have that, and it's very, very uncommon, but I tell my patients for exactly that reason, it's not 0. And if it happens, I don't want you to come back and say, John, how did I get ovarian cancer? You took out my ovaries. It's not real ovarian cancer, it's peritoneal cancer that behaves like, presents like, and we treat it like ovarian cancer. And it can be understandably devastating.
Okay. I'll take one more question,
Of course.
if I can. From a patient to doctor aspect, how do you then get a diagnosis of breast cancer? I'm putting myself out there. 3 years later, get a clear, go live your life, you know, you're in the clear. 3 months after that, you're diagnosed with ovarian cancer after having been cleared, then one of my oncologists, OBGYN, said, well, I wouldn't remove your ovaries, I would remove your cervix and your uterus. Never talked about ovaries or fallopian tube, and he said, actually, if you remove your ovaries, I'd put you at higher risk for heart disease. Now, how do you as a patient then think about, you know, because you're going through 2-3 specialists, then how do you then advocate for yourself? Well, this doctor is telling me this. I would be at a higher risk for that. I don't have an oncotype. I don't have a BRCA gene. I don't have this. These are things that I found out after the fact. So then how do you advocate for yourself to say, well, this doctor is telling me this other doctor is telling me that, but now I'm in the clear, like, oh, you know, and then suddenly, you know, the lightning strikes.
Yeah.
And then, so how do you then take a positive approach where you're positively going in the right direction, but then, okay, do I want a risk of heart disease versus a risk of ovarian cancer? Even though I'm not in that pool of people, how do you make those?
Yeah. So every day I have a discussion
Yeah.
in my office, right? So if a woman comes to me, so I mostly have cancer, but I'm a pretty good surgeon, so I get a lot of benign cancer stuff sent to me, fibroids, things like that. So if a woman comes to me for a large uterus, she wants to have a robotic surgery for fibroids, I tell them, if you don't have germline mutation, if you don't have family history, you should keep your ovaries. And those recommendations come from our society, ASCO, and ACOG. And the reason being is the #1 killer of women is not breast cancer, it's not ovarian cancer, it's not breast and ovarian combined, it's not lung cancer combined, it's heart disease, okay? And keeping your ovaries protects your heart. And that benefit lasts until the age of 65. So when I was a medical student, we used to say, you're gonna have hysterectomy at 43, stick your ovaries out, we're gonna reduce your risk of ovarian cancer. It sounds really good, but then they did a study in Harvard when they took Harvard nurses and they compared nurses who had hysterectomy with their ovaries removed and those that didn't. And the women who kept their ovaries lived longer. No doubt about it, okay? Now, again, the problem is, what do you do individually? And your risk, if you don't have a BRCA mutation or personal history or family history, is 1.4%. But what if you have a personal history of breast cancer? If you have a personal history of breast cancer and it was diagnosed before the age of menopause, you now have a 5% risk of developing ovarian cancer. Still low, 95% risk you're not going to. If I was on Channel 7 News, I'd tell you it's 3 times higher. But it's still only 5%. It's not 0, right? And so we have to give you the best information that we can. And most of my women today will keep their ovaries. And when we talk about an Annie, we'll talk about a surgery that I do in South Florida that's called quítame todo. And my little Hispanic ladies come in and they say, quítame todo. I want everything out. You gotta keep your ovaries. I don't want to hear it. I want everything out. And that's okay. In the end, we have to, I tell them, you're the boss. I have to give the information, you gotta process it, and you can say, John, I hear you, 5%. That's too high for me. I saw what my best friend went through, I'm not risking it. I promise I'm gonna eat more, I'm gonna stop eating pastelitos, I'm gonna work out as much as I can for my heart. But I don't want that risk. And that's okay. Remember though, a lot of cardiac risk is not modifiable. A lot of cardiac risk is just, if you're Cuban, you're Cuban. Can't do anything about that. So, yes, it's good to do those things, but there's some things that are limited, okay? So real quick, and then I'll take some questions again. I know I'm over time, sorry. Cervical cancer, screening for cervical cancer, pap smears, right? No one should get cervical cancer in the United States, okay? And in fact, we have a very low pap smear rate. Cervical cancer rate. Only 12,000 cases of cervical cancer every year in the United States. 50% of those women have never had a pap smear in their life. They either come from outside the US, or even worse, they live in the US and don't have access to healthcare, okay? So routine pap smears and HPV testing, okay, starting at age 21, regardless of when you start intercourse, okay? Other things that you can do is the Gardasil vaccine, and again, I don't get paid by Merck, at least not for that. Gardasil vaccine, it's a 9-valent vaccine against HPV, okay? Everyone should be getting that, boys and girls. I have 2 boys, my older one is 15, he got his vaccine. If you get it before 14, it's only 2 shots. If you get after that, it's 3, so John was happy to say, yep, I'll take 2 shots. My young one will get his next year, okay? And the reason being is no one should be getting cervical cancer. In the past, we would say boys should get treated to herd immunity, right? So we can't get all the women, but we get some of the boys, some of the girls, and it's herd immunity. Now we know that a lot of head and neck cancers in men are HPV related. This is a nice crowd. If I can say you guys know Michael Douglas, and you guys will say yes. So Michael Douglas had head and neck cancer. It was an HPV-related cancer, okay? His ex-wife got really upset that he said that. But that's what it is, okay? So It will help protect boys from other HPV-related vaccine cancers, and also helps protect against genital warts, which in young girls can sometimes be even more devastating, having an abnormal pap smear. But no one should really be getting cervical cancer in this day and age. Okay. Go ahead.
I have one question, and then we're gonna close it out, and then you guys can all see Dr. Diaz at the end if you have any questions. So obviously, if I shared my story, is there any updated literature on using hormones for women who took preventative action that are BRCA2?
So that's a great question. So we just had this discussion yesterday at our tumor board. So if I have a patient and she's BRCA1 positive, and she's decided she's going to do a prophylactic mastectomy, and she's also going to remove her ovaries, yeah, I start them on hormone replacement. They're 32, 34. Again, cardiac risk, osteoporosis, just general health. Okay. So yeah, I do start them. If you remove the uterus, it helps with simplifying hormone replacement therapy, right? So if you keep your uterus, you need both estrogen, which is what gives you what you need, and progesterone to counteract your estrogen for the uterus. If you remove the uterus, you only need the estrogen. And if you look at the WHI study, it was the combination of estrogen and progesterone that had the increased risk of breast cancer. Okay, so young patients who are going to that should be receiving some kind of hormone therapy if they're really young. Remember, we can't screen for ovarian cancer. We can screen for breast cancer. So you can get your mammograms, you can get your ultrasounds every 6 months. So if there's an increased risk, it's going to be minimal, and we're going to catch it. If you had a prophylactic mastectomy, then really unlikely. Okay. The hard part becomes, right, when do you stop? Right? So women who are on oral replacement therapy feel great, you know, but at some point you got to cut it out. And so there's not great guidelines on that. Okay?
Perfect.
Yeah.
Thank you so
Yeah.
much.